it's a hard time to learn how to be an adult. It's
Totally.
not hard. That is my message to kids.
It is.
It is not hard to have a heart transplant,
No.
to live with a transplant. It's just hard being an adult. When someday
I still have that.
you pay exactly. I'm like, I never.
You should totally mentor.
Yeah. And you know, I mean, the other thing is, they didn't think they were going to make it to adulthood. I mean, they really had the mentality that they were going to get through their childhood and that was going to be it. I mean,
Well, and I think that depends, because I think what's different too, and then I'll get off my soapbox, but like, is when a lot of these kids who are kids were sick from birth.
Right.
Whereas a lot of the treatment you get assumes you were fine. They're like, okay, you're fine now, and we don't know what that means. So we don't know that once you get that heart, you're not just gonna not die.
Right.
You're gonna feel much better. You're gonna be able to walk and not, so like, because I mean, we never knew what you're supposed to feel like. So it's a hard thing to describe. So I get it, yeah. And I mean, and like I said, it's hard to figure out what you're supposed to do now that you're healthy. And the rest of us are still trying to figure out how to even be an adult. How do you pay your bills? How do you get your pills?
It's very true. I mean, yeah, you're absolutely right. And a lot of our kids were transplanted as 30-day-old infants, so they haven't known anything different, And they get to, they graduate high school and then they don't have any clue as to what they're going to do. Because they don't think, they just weren't, I don't know, it's very tough. Very tough. And they are I'm telling you, I have a handful of kids we've seen this past year that are darling, awesome personalities, awesome parents, but they're very, frustrated, they're very depressed, they're very, they struggle. And they want somebody, to talk to.
We will find something for them.
Yeah, it'll be, it's a bit, and we've had a couple kids transition from other programs that have moved to the area, and they're like, do you have people that we can talk to that have been through this? So, it's been asked and asked and asked again, of us. It's been...
Cindy, when we met with Dr. Kidd about this time last year, and that was his big thing that he wanted to do that. So we've been gradually trying to do that. I think you're correct in that it almost has to be a subdivision of HTA where, every other month maybe they're asked to come to meet with us. But there's a lot of things that we could do to support them financially, without reinventing the wheel.
I agree.
So when you get, once you get it up and running, let us know and we'll.
Because I know Rachel Economou is one of the people that moved to the St. Louis area, and she wants to, kind of be active in it. She lives in U City, and I don't think she's interfaced with you guys very much, but I think she could benefit. Yeah, I will. Because, she's very excited to kind of, and I know there's some sort of transplant kind of Facebook page, or it's kind of a national thing that she's been on, maybe. But, it sounds a little bit of a loose cannon, like, I don't know.
Well, one of the problems is that through the hospital, through the system, there's that bureaucracy. And getting through all the different levels, we now just have been able to interface really well with the social workers.
Yeah.
We just became the mentors and the ambassador program that takes care now of all the LVADs and all of transplants. So we're mentoring for all of the phases at Barnes. And then the next phase is to do exactly as the obviously we went, Sharon and I had a youngster
exactly.
that went from children, so we're very much
Yeah, that'd be great to just, kind of help, augment that effort to, get those kids.
I'll give you my card and pass it out.
And well, I really do, and I know there's been a reservation, and I kind of think this is wrong, that, okay, well, if we hook these kids up and some of them have bad habits and bad ideas, well, you can't control that. They are what they are. They're kids, and if they can get some degree of support and encouragement from each other, you've done a good thing. Are they all going to live to be 80? Probably not, but at least they can support each other and get some, and that's what you all have done for each other. We're all in this, kind of together to support each other and make the journey a little bit easier and better. So, absolutely. Yeah. Amen.
Not me.
Oh, yeah.
a little crazy.
It's all over the place. There's a lot of people who are new, who are asking questions easier, they should be asking their doctor. A lot of people are very silly. There's your choice. So, it's interesting to read the comments, but it's kind of one of those things where don't ask your questions, you're
And that's what, that is true. And I mean, we always say at every meeting, don't compare your meds to the next person's. Because what we've got you on is what's good for you. And every person's different. Everybody's, metabolizes the meds different. It's just different across the board. What you require to keep you out of rejection is different than what the next person requires. So, and you're right. If you have a question, ask one of us. Absolutely. So, that's a good food for thought. Thanks for that input. And just along those lines, we really do get about 80 to 110 transplants or heart failure referrals a month. It's pretty amazing. We are a kind of a center that gets called upon to consider people for advanced therapies. We kind of see all kinds. We see young, we see old, we see people that really should probably progress to hospice, but they want to check out, is there any option for me to get an LVAD or get put on an IV medicine to help my heart failure. So we stay very busy with those new referrals as well. The other thing I wanted to point out, because your numbers are different than our numbers, so we did just reach the 821 heart transplant mark. But our numbers are different from your numbers because we, in the early years, combined St. Louis Children's Hospital numbers with our numbers because we had the same surgeons doing the transplant. In the first year, we did one pediatric heart transplant, and then it kind of ramped up from there. And finally, until 1993, when the Children's Hospital program really took off under Tom Spray's guidance, we really kind of decided to separate. And at that point, Dr. Huddleston kind of took over the reins, and they were doing so many. We used to kind of combine the statistics, even though they had children's coordinators that we all trained, but that's why our numbers are always different. Yours are a little bit smaller than that, as far as the number you give to each heart transplant patient coming in. And again, like I was saying, we really do transition an average of about 5 patients per year from the pediatric program. So those are kind of a population that we need to kind of pay attention to and think about how we can make it a little bit easier road. And this just kind of shows you our numbers through the years. We had some low transplant years. I can tell you that was mainly out of competition. Children's program was very busy, as well as St. Louis University program was very busy. So we had 3 really active, busy programs in St. Louis area. So our transplant numbers went pretty low those years. About the late 2000s, 2006 or 2007 is when St. Louis University program closed for active heart transplants. So that's when we started getting a lot more, as well as the LVAD program kind of fueling our need for heart transplant, raising our acuity. And that's why our numbers have kind of been high and stayed high. And then I just wanted to show the last 5 years we've been very active under the tutelage of Dr. Silvestri. We hit an all-time high of 41 last year. Very complicated patients, you all are, with the LVADs, but again, it's been overall a pretty successful couple of years, and for sure the last 5 years. So I just wanted to touch a little bit on how different our protocols are. I can tell you when I started with the program in 1987, we biopsied everybody for forever. We did biopsies because we didn't really know what else to do. We did echoes and biopsies just because that was the way we monitored people. These days we have the use of AlloMap, which has been awesome because it's a blood test, and in a stable patient, you know, we can check the AlloMap and know that they're kind of at low risk for rejection. So really, the potential of the way we have it set up is you could get by with 10 to 12 biopsies for your life. I can tell you after traveling around the country and talking to different programs, this is very unusual. There's a lot of programs that bring patients back year after year after year and biopsy them every single year. You bring a patient in, their echo's normal, they're stable, they're doing fine, they still biopsy them. And what we found, and what Dr. Ewald kind of led the movement to do, is to look at those patients and say, okay, we're biopsying patients and have normal heart function, they look great under echo, their casts look fine, they feel great, why are we biopsying them? And about 95% of those biopsies were negative. And we're subjecting them to, you know, a potentially harmful procedure where you go across the tricuspid valve, you can injure the valve. So we've stopped doing biopsies after year 1 as long as everybody looks good and doesn't have any rejection. That's a big difference. Yeah, I'm here for no biopsies. I know you guys like getting jabbed in the neck or the groin, but and AlloMap has made a huge difference because literally we can do one biopsy after month 6 and we can check AlloMaps the rest of the time. Recently, some of my colleagues in heart transplant on the East Coast have looked at using AlloMap for when you adjust people's immunosuppression rather than doing biopsies. Just check an AlloMap if you have a baseline. So it's really, the use for AlloMap has been expanding as far as monitoring patients and trying not to do so many biopsies. They're also looking at it in pediatrics. Because, number one, it's a really expensive test, and if you're stable, we have kind of felt, that the benefit of an AlloMap probably isn't there, as, we'd rather do an echo and make sure that your heart function is good. There's certain signs that echo shows us if your heart's struggling or having any issues, and at that point we would just proceed to biopsy. But that being said, Judy, it's a really good question because there are programs that are looking at, okay, if you reach the 5-year mark or the 10-year mark, maybe what you could do is reduce the anti-rejection medicine and monitor your results with AlloMap studies. So there are some programs that are doing that, and one of the programs submitted their abstracts to the ISHLT, which was in Nice, France this year, and the coordinators got to go to Nice and present their abstracts. So,
How was it?
not these coordinators. Dick Cheney's coordinator got to go from the East Coast. I met her. She's a liberal, and she was afraid that the Secret Service would find out that she was a liberal and fire her from Dick Cheney's care. So, it's true though. No. And Dick Cheney had an LVAD and got a heart transplant. He's doing well. Nothing like violating HIPAA here on camera and the internet. Anyway. But it's a good question, and we really are looking at potential for that for the future, just as a way of, because we have seen a trend. Sometimes after people are out, so far their program levels maybe don't need to be so high. And maybe what you could do if you reduce their dosage, monitor their AlloMaps. I know. It is a tough balance. We'll see kind of what the future holds for that. Our general approach right now, it hasn't changed for some time, is we do a cardiac catheterization at years 1, 2, and 3. And if the coronary arteries look good, then we do stress testing for the next 2. And really, generally speaking, we do stress tests every 2 out of 3 years. We get full labs at your annual, and then for life, we do want you to get labs every 3 months. Val.
I know.
I have to hit on her every single time. And Johnson, you do not have any room to talk. it's when we come up for an annual evaluation, we go, really? Has it been a year since they've had their labs drawn? So, anyway, we really do. And, I recently, just this week, I admitted a patient who had a gross abnormality in her labs, and she's great about going, and probably has a, big platelet problem. But that's where it comes in. You can have really funky things turn up. And so it helps us to know what your, labs are, and especially for kidney problems. Yes, sir.
Hi. I had a quadruple bypass 3 years ago. My brother had the heart transplant, but I've never had a catheterization since my quadruple bypass.
How many years ago?
It'd be 3 years, April 7th.
Do you follow with a
October the
cardiologist?
7th.
Is he doing stress tests?
I did none of them.
Do you see a cardiologist?
Washington.
I have no answer for you.
I go for me.
You could have one of our staff. We'll delegate it.
Yeah, there you go, transfer to EWOL. That's a tough one, because, there's kind of have you had an echo or anything like
I
that?
had nothing.
Have you tried any symptoms though?
No,
Yeah.
I haven't
So
had
they
to
kind of
take
monitor symptoms.
nitro, nothing.
Yeah. So,
I've got an appointment coming up next month, the 4th. It's first.
I would say this, I would say, just to discuss kind of the long-term plan, as far as like, would you, what's the, plan for kind of checking the grafts out. Chances are they're doing great, and especially if you're doing everything you want to do. The interesting thing about bypass is that the grafts last much longer than the stents that they do. So that's the reason they do bypasses, because they actually have a much longer lifespan. But, you may want to say, how do we know, I'm feeling great, but, is that the only parameter of testing for, figuring out whether those grafts are doing well? But they do have a very long lifespan. So, the therapy was right. They last a lot longer than stents. It's just a bigger procedure.
I'm going to study at 15 shots.
Oh.
Still?
it's trying to keep I was so proud of myself for wearing something.
But now it's so
Anyway, this is just a little reminder of things we want to be notified of. If you change your local physicians, address and phone numbers, of course. Insurances, our gals are great at kind of letting you know what we take and what we don't, and if they don't know, they'll find out for you. Again, things are changing so frequently with regard to insurance carriers and who takes what, and we have two entities. We have WashU and we have Barnes, and sometimes WashU leads the charge to accept an insurance carrier, and sometimes Barnes does. And usually the other one will follow, but it's a very complex and difficult issue, as Arlene Thomas will tell you, right? And anytime you get medications prescribed by an outside provider, we want to know about it. Again, there's sometimes side effects that, people don't understand or don't know about. And anytime you have a health issue, I know sometimes when you call about a problem, some of our secretaries will say, you know what, you should call your primary care. We still want to know about them, though, honestly. We want to know about everything. So even if it's not our primary domain, we still want to know what's going on with you, just so we're kind of clued into it. And, if there's something we see that's particular to a transplant, we can kind of let you know, kind of steer you in the right direction anyway. So as far as the short-term challenges, and this is kind of where our way of monitoring patients comes in, with regard to rejection, there's two types. Cellular is the most common. It's what you pick up on a biopsy, very easy to detect, very easy to treat, usually responds to steroids or other medicines. The antibody-mediated rejection, that's kind of the problem that we're still fighting, and the problem that we lose the most patients to. It's, what Casey succumbed to, and can be very difficult to fight. It occurs more kind of in a more potent way in young people. It's because the immune system is just a very tricky thing to outwit, and antibody-mediated rejection has to do with having antibodies that recognize the heart as something they've seen before, and so it's very difficult to treat and get ahead of. Yes, Ken?
Last time, I had Dr. Sheehan, wasn't he doing research with antibodies?
Yes, he's doing a lot of research. Because there's some...
He said he's got some good things come out. Don't know
No, because I'm not going to blind you with science. No, I'm kidding.
Is it progressing well?
You know, it is. They're finding out, you know, he's also looking at native coronary disease as well, and there's some interesting things he's been finding out. But there are some cell lines that they find out if they, you know, go against those cell lines, they can kind of get ahead of the antibody-mediated rejection. I will say we've probably never been so tuned into antibody-mediated rejection as we are now, and getting ahead of it and treating people very aggressively if there's any hint of it. Doesn't mean that we don't still lose people to the battle of antibody-mediated rejection, but I feel like we kind of you know, try to really jump on it. The other thing that we're doing along these lines is, you know, we still try to wean everybody from steroids. But now what we're doing prior to that wean is we're checking their, to see if they have antibodies against the heart, because we always tissue type the heart. And so if they have antibodies,